Why do we need guidelines? As neonatologists, we all know how to look after babies with RDS. We know that they need support with supplemental oxygen, non-invasive and invasive ventilation, as well as surfactant therapy. Many of the things that we do for babies like this are life-saving, but unfortunately many of the things that we do also have the potential to cause harm, such as too much mechanical ventilation can injure the lungs, and too much oxygen can be harmful. The European Guidelines Group do this. They make recommendations, and then they try and grade the strength of the evidence supporting the recommendations using grade methodology. Firstly, if a baby is at risk of delivering preterm, it's important that the baby be transferred to a perinatal centre with a high throughput of very low birth weight babies, as outcomes have been shown to be better if babies are born in such centres. Obstetricians should offer a single course of prenatal steroids to mothers at risk of preterm birth from when the pregnancy is considered viable up to about 34 weeks gestation. There's very strong evidence that this will reduce RDS and save lives. Babies should be also given, or mothers should be given, magnesium sulfate if they present in preterm labour, as it will reduce the risk of cerebral palsy. And it's reasonable to consider short-term use of tocolytics in order to allow steroid course to be completed or to allow safer transfer of the mother to a perinatal centre, but they should not be used routinely. One of the key issues that we have to tackle is how do we get a baby to have 60 seconds of delayed cord clamping? And what do we do with the baby during this first minutes of life after birth whenever we're trying to promote a placental fetal transfusion? So what are the delivery room stabilisation recommendations? We should of course start by planning to delay cord clamping for at least 60 seconds, because this will save lives. If delayed cord clamping is not feasible, then umbilical cord milking might be considered as an alternative, but only for more mature babies, as there are concerns about increased risk of intraventricular hemorrhages for babies who are born under 28 weeks. What about surfactant therapy then? What are the considerations for surfactant for RDS? And we can see clearly from the data in the Cochrane review that compared to Insure, LISA surfactant will reduce the need for mechanical ventilation in the first 72 hours after administration. And we can also see that LISA compared to Insure reduces the combined outcome of death or chronic lung disease. There have been a number of studies on surfactant nebulization, and consistently these show only modest benefits, and it's not at the moment in a situation where we could make any recommendations for surfactant given by nebulizer. However, there have been studies where surfactant has been given successfully by laryngeal mask. Babies with RDS needing treatment should be given an animal-derived surfactant preparation, and LISA is the preferred method of surfactant administration for spontaneously breathing babies on CPAP. And if we're using poractant alpha, we should use the higher initial dose of 200 per kilo compared to 100 per kilo, because this has been shown to reduce mortality to the high dose compared to the low dose, as well as to 100 milligrams per kilo of poractant. Non-invasive respiratory support with early rescue surfactant using the LISA technique is considered the optimal management for babies on RDS. The system delivering CPAP is of little importance. However, the interface should be short binasal prongs or mask with a starting pressure of around 6 to 8 centimeters of water. High flow nasal cannula can be used as an alternative to CPAP for some babies, with the advantage of less nasal trauma, provided centres have access to CPAP or NIPPV for those who are failing on this mode. Of course, we should use mechanical ventilation in babies with RDS when other modes of respiratory support have failed, but the duration of mechanical ventilation should be minimised. If we have to ventilate, we should use lung protective modes such as volume targeted ventilation or high frequency oscillation. And when weaning from ventilation, it's reasonable to tolerate a modest degree of hypercarbia provided the pH remains acceptable above 7.22. And it's also very important to train staff to avoid hypocarbia, which can be harmful to the developing brain. Caffeine in a loading dose of 20 per kilo followed by 5 to 10 milligrams per kilo maintenance should be used to facilitate weaning from ventilation. And early caffeine can be considered for babies at high risk of needing ventilation such as those on non-invasive respiratory support. And a short tapering course of low-dose dexamethasone should be considered to facilitate extubation in babies who remain on mechanical ventilation after 1 to 2 weeks. And we should avoid routinely using opioids for babies on mechanical ventilation. So that's everything. Thank you very much for your attention.